Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Please be seated. After a nice and big smile, we need to proceed to our sixth session of the day. That's the thyroid. And as the tradition of the PES session, I'll first call upon the panelist of the session. I am Dr. Suleiman Ilahi Malik, and I am a consultant endocrinologist at Khyber Medical College and Khyber Teaching Hospital. The first panelist of the day is Dr. Najmul Islam. He's the professor of medicine and endocrinology at Al Khan University Hospital, Karachi. Sir is the dean and convener of endocrinology, CPSP, College of Physicians and Surgeons, Pakistan, and more than 100 publications. He is the ex-president of Pakistan Endocrine Society as well. The second panelist of the day is Dr. Khatija Irfan. Madam is the professor of endocrinology at Services Institute of Medical Sciences, Lahore. Madam is the member of the faculty committee of College of Physicians Surgeons, Pakistan, and Madam is the member of the curriculum committee of endocrinology at University of Health Sciences, Lahore. The third panelist of the day is Dr. Khalid Usman. He is the associate professor at Hyderabad Medical Complex, Peshawar. Sir has a vast experience in treating diabetic and endocrine patients. Sir, please join us on the stage. Now we have three speakers for this session. Now I am going to announce the first speaker of the day, Dr. Syed Ali Imran. Sir is the professor and chief of endocrinology at Dalhousie University, Canada. Sir has a great interest in research of neuroendocrine disorder and thyroid cancer. Sir, stage is for you.
Thank you very much again. Much appreciated. I think those of you who were here in the morning, I had the opportunity to interact with them. This is the second talk, which is about thyroid cancer. And I was given the topic to discuss approach to low-risk thyroid cancer. These are my objectives. I'm just going to talk about how we define low-risk thyroid cancer, what are the appropriate surgical management of low-risk thyroid cancer, concept of active surveillance, which is basically just doing nothing and following these patients, role or lack of it of radioactive iodine therapy, and finally the role of TSH suppression. I do want to say that I'm going to present some guidelines, so I'll ask you not to take pictures because some of these are not published yet. I'm going to start with a couple of cases. Case number one is a young female who presented with an 8 millimeter thyroid nodule. We did a fine needle aspiration biopsy, turned out to be papillary thyroid cancer. She's otherwise healthy. The question is, what's the next step? And the second case is a 67-year-old female presenting with slightly larger, a 9 millimeter thyroid nodule. Again, evidence of thyroid cancer with some comorbid conditions. And the question is, what are the next steps? How do we deal with these patients? Now, for those of you who deal with thyroid cancer, it shouldn't come as a big surprise that thyroid cancer is getting increasingly common worldwide, and that's primarily because we are beginning to use these fancy sensitive imaging techniques like CT scans and ultrasound scans. As a matter of fact, these data came out of Sears, a US database, and essentially showed that if you were to look at this graph particularly, showing that over the last number of years there has been a gradual increase in the incidence of thyroid cancer. But most of this is driven by low-risk papillary thyroid cancer, whereas if you were to look at the poorly differentiated or follicular thyroid cancer, that's pretty much straight. So it's all driven by low-risk papillary thyroid cancer. These are data from South Korea, and again showing very similar feature. This took off over here in the early 2000s, very high, rising incidence, but standardized mortality has not changed at all, and most of it is coming from increased detection of thyroid cancer, low risk thyroid cancer, which is less than 2 centimeter with ultrasound. So essentially what the point I'm trying to make here is that the more scans you do, the more likely you're going to find these small cancers. Now, how do we define thyroid cancer? We can all talk about horror stories where some patients who had low risk or apparently low risk thyroid cancer, but when you actually looked at them, they ended up having bad metastatic disease. Now, in this case, the way we have defined it, and we have written these Canadian guidelines, it is based on risk of recurrence being less than 5%. So anything that's less than 4 centimeter, N0, N1, less than 5 lymph node with a 2 millimeter and no extrathyroid extension except microscopic extrathyroid extension, which doesn't change your risk. If you give radioactive iodine therapy, there must be no extrathyroid radioiodine focus. If total thyroidectomy, then thyroglobulin should be less than 1 to 2.5 with no antibody. Specifically for papillary thyroid cancer, no aggressive pathology, no BRAF mutation, no angio invasion, and specific for follicular and oncocytic, minimally invasive, are less than 4 foci of vascular invasion. So this is how we have defined low-risk thyroid cancer. These guidelines should be coming out soon, and they will be available to review. So this is the current paradigm of dealing with thyroid cancer. We have to make decisions. Are we going to recommend partial thyroidectomy, total thyroidectomy, lymph node level 6 dissection, lateral dissection? Should we give iodine treatment? How much TSS suppression? And to this particular paradigm, now we are adding another step, which is, should we actually do anything for these patients or just continue to watch them? Because the men over the age of 80, if you actually take out their prostate, many of them are going to have prostate cancer. Similarly, thyroid cancer, they're extremely common. So do you really need to do anything for these patients? That's the concept I'm going to discuss with you as well. Where did this come from? This actually came out of an elegant work from Japan, where they had these 2 centers in Tokyo and Kuma, and they followed approximately 1,500 patients, and these were sub-centimeter, less than 1 centimeter thyroid cancers. They did not do anything. They confirmed the diagnosis with biopsy and just followed these patients. And they basically showed that over a course of 10 years, 90+% of these patients had no progression in their thyroid cancer. They did fine. And those who progressed were more likely to be younger and pregnant females. So that's where the concept of active surveillance came into existence. What about larger cancer? This was sub-centimeter, less than 1 centimeter. What about up to 2 centimeters? So my team and I are doing a study in Canada, where we are now looking at cancers as large as 2 centimeter, and our preliminary data are basically suggestive that they may not need any further treatment either. So these data will be coming out hopefully in the near future. So active surveillance wise, if your tumor is less than 1 centimeter, even up to 2 centimeter, no aggressive feature, you could potentially follow these patients without doing anything. If the tumor is away from the trachea, recurrent laryngeal nerve, no bad sinister looking lymph node on the ultrasound, you could follow them. Particularly older patient, remember younger patients are more likely to have advancement, and the patient has to accept it, and the team has to accept it, because this is not something, you can't just forget about these patients. Patients and the team has to accept them. What about if you decide to have surgery? What type of surgery and how much surgery you need to do? And these are the European and the American guidelines, which are obviously being changed. Look at this total thyroidectomy versus lobectomy. So we don't have any thyroid surgeons here, but if you were to look at lobectomy versus total thyroidectomy in these patients, this is almost 23,000 patient data, showing that the outcome, this is a Kaplan-Meier curve, their survival is pretty much identical to each other. So for low-risk thyroid cancer, you don't need to go whole hog and just whip out their thyroid and whip out their lymph nodes. You're basically just going to cause a lot more complications, as shown in this particular meta-analysis, that if you look at their survival and risk of recurrence, there is no difference. It's on the line of unity. But if you look at the complication risk, clearly high rate of complication with major surgery. So there is no need for surgeons monkeying around with these patients and do a complete thyroid removal, particularly in small, less than 1 centimeter papillary thyroid cancers. So these are the guidelines. If your tumor is larger than 4 centimeter with extrathyroid extension, clinically nodal, apparent nodal mets, distant mets, family history, radiation therapy to head and neck area, go for total thyroidectomy. If it's 1 to 4 centimeter, no other features, you can do total thyroidectomy, but most likely lobectomy is just fine. And if it's less than centimeter, probably less than 2 centimeter, then either lobectomy or just active surveillance would be just about right, if your patient is in agreement with it. Role of radioactive iodine therapy, this was my contribution to the guidelines. This is the chapter I wrote. So a baseline serum thyroglobulin should be obtained at least 4 weeks after surgery in case of total thyroidectomy. And there is no role for routine radioactive iodine therapy in low-risk thyroid cancer. I'm not recommending it. Serum TSH must be normalized. If your thyroglobulin level post-total thyroidectomy is greater than 2.5, that means there is quite a bit of tissue, and that is a case where you might consider low-dose radioactive iodine therapy, maybe 30 millicuries to 50 millicuries, but no more. No need to go crazy with that. What if you do not want to do surgery? What are the non-surgical options? Well, there are actually quite a number of them. This is a fantastic approach. Is radiofrequency ablation. It's just like a probe of a microwave. So we are doing this, our center is the first in Canada where we are doing this technique. Essentially, we put a probe into the thyroid nodule or thyroid cancer and you fry it. And this is you don't need to do anything else. And if you look at these small thyroid cancer, these are data from Korea again. They treated over 150 patients, and basically over 90% of the tumors, they disappeared over time. So it's a fantastic technique whereby you do not need to really operate on these patients. Hopefully next time when we meet, I'll show you our own data, because we have started this technique in our center. If anybody is interested in learning or training, please contact us. We'll be happy to bring you for a little while and train you in this technique, because we are doing it. The other possibility is basically using ethanol. Ethanol has been used for many, many years. So percutaneous ethanol has been used in some centers. This is data from Rochester. And I don't particularly like this, because if you spill ethanol out of the thyroid, it's an intensely painful injection, and it can cause a lot of fibrosis in the neck. So you have to be really, really slick if you are going to do it. But the data are again quite interesting. They showed that there was a median shrinkage of 93% over time, and they treated 15 patients. So the concept is the same. These small thyroid cancers, low-risk cancers, do not necessarily need surgery. What about TSH suppression therapy? Well, this is again, there are no prospective studies, none. So these are the data which we obtained from the same Japanese study. They looked at the patients, about 1,235 patients. They, in their group, inactive surveillance group, did not require TSH suppression or were not prescribed TSH suppression. About 50 plus were given TSH suppression, and the rate of progression was higher in those who had no TSH suppression versus those with TSH suppression. TSH suppression does not mean that you push the TSH below the normal level. It's just keeping it toward the lower end of the normal range. And essentially, if you are, what we have suggested in our guidelines is to keep the TSH under 2, which is really toward the lower end of the normal range. So That's what we are suggesting at the moment. So going back to our two cases that I presented, question is, what are we going to do with them? They are in your clinic. What are you going to suggest? So looking at this particular chart that I had suggested, I think we will agree that this is a young woman who has a sub-centimeter tumor. She probably would not be the ideal candidate because she's a younger female, and we don't really have data. But this particular patient would be an ideal patient for active surveillance. I would not recommend her anything. I would just say, I'm going to follow you and I will not do anything. You're probably going to outlive your cancer. This is a paper we published recently, not recently, now a few years ago, and why am I bringing it up? I'm bringing it up because as an endocrinologist, I follow about 1,500 thyroid cancer patients in my clinic. It's an unmanageable thing, and this, as with the numbers are rising, you're going to end up with all these patients. So we cannot continue to follow that. So what we have decided, we wanted to see if our primary care colleagues, I don't know if there is any family physician here, or our general internal medicine colleagues, but these patients can be effectively followed outside the endocrinology service. And what we showed basically that if these patients were compared to tertiary care versus primary care, they were effectively followed, and we saved money because the cost of care was by far significantly lower in primary care setting, clearly showing that you can actually manage these patients. So take-home points are as follows. Most differentiated thyroid cancers, specifically less than 1 centimeter or even less than 2 centimeter, may not require immediate surgical treatment. Active surveillance, or preferred deferred treatment, if you want to say it, is a reasonable option for these patients. For those patients who do not feel comfortable with active surveillance, non-surgical options like radiofrequency ablation, even ethanol, might be feasible. Data on TSS suppression there are required. We don't have enough. These patients will require intensive follow-up for the rest of their life, because if you're not operating on them, you can't use the traditional markers like thyroglobulin and stuff. You're going to rely on ultrasound and clinical exam. That's why more intensive follow-up, which will increase the workload for endocrinology, and therefore these patients need to be seen more by primary care. And that's where I think we need to train our primary care colleagues, and hopefully that should help them. So thank you. I managed to give this within 20 minutes. I rushed through the topic. Will we be taking questions afterwards, I guess? Or we have a few minutes if somebody wants to ask a question. I have 3-4 minutes, so...
We can take questions really because we have a few minutes left for the presentation.
Assalamu alaikum. My question is that is there any tumor marker available to detect early stage cancer in thyroid?
Thank you. It's a good question, actually. So the tumor marker we use traditionally in thyroid cancer is thyroglobulin, which is the protein produced by the thyroid gland. And when you remove the thyroid gland and give iodine therapy, there should be theoretically no thyroglobulin, and that's what you monitor for. The problem is when you have an intact thyroid, whether it's half the thyroid or full thyroid, then really thyroglobulin doesn't help, which is what I was saying, that thyroglobulin or traditional markers of biochemical marker would not be useful. That's where you're going to rely on your physical examination and ultrasound scanning. You have a question?
Thank you, sir, for an amazing talk. My question is that in your experience, what are the most favorable prognostic factors when you diagnose somebody with...
Favorable?
Favorable or an unfavorable.
Young female, small cancer, obviously, no lymph nodes, no risk features on pathology, lack of extrathyroid extension, no lymphovascular invasion. So those are the key, but clinically, young females tend to do better.
Okay, thank you.
Yeah, no worries.
Thank you, sir, for a nice talk. So my question is, in patients with multinodular goiter and the nodules are sub-centimeter and the thyroid ultrasound is not that much suggestive of any malignancy or a cancer, then what is your concern about that in following those patients?
So multinodular goiter, you have to look at each nodule separately. Whichever is high risk, you biopsy that. And the sonographer will be able to tell you if it's a thyroid 1, 2. Use the thyroid classification. It's a thyroid 1, 2, 3, 4. Whichever is high risk nodule, you biopsy it. And if it is malignant, then you follow it. If it's a small tumor, just use the same approach. Multinodular goiter is no more different than single nodule. You use the same set of guidelines.
I want to ask, what is the role of thyroid antibodies?
What is the role of?
Thyroid antibodies. For example, TP antibody or TG antibody.
It's a good question. So, thyroid antibodies are of different types. If you have positive anti-TSH, anti-TPO antibody, which is Hashimoto's thyroiditis, you are slightly more likely to have thyroid cancer, slightly. But that does not change my approach. If I see somebody with slightly positive antibody, that's not going to make me jump up and down and say, well, so it's not a big risk. I think I'm running out of time. So
I just wanted to add this, my comments to this question. Anti-thyroid, thyroglobulin antibodies is used simultaneously along with serum thyroglobulin measurement so that we can rely on serum thyroglobulin. Maybe that's what he wants to answer.
Oh, sorry. There is an antibody called anti-thyroglobulin antibody. What anti-thyroglobulin antibody is, when you measure thyroglobulin, the way thyroglobulin is measured, and I can show you on my computer afterwards, you basically, anti-thyroglobulin antibody interferes with the way we measure thyroglobulin and gives you a false negative result. I'll show you a scan. So that, in that case, we use that as a surrogate marker. But beyond that, I think there is no role.